All right, as those attendees trickle in and the numbers climb, I'll get started. Hi everyone, welcome to our 41st seminar of the Centre of Research Excellence in Aphasia Recovery and Rehabilitation. I'm Dr. John Pearce, a postdoctoral researcher at the Aphasia CRE and co-facilitator of the seminar series with Dr. Sonia Brownson. Before anything else, I'd like to acknowledge that this event and many of our participants are located on the lands of traditional custodians in Australia, and today I'm speaking to you from Wurundjeri land. We pay our respects to elders past, present and future, and extend this respect to any First Nations people joining us today. Today we have Dr. Jade Dignam joining us to talk about a modified intensive comprehensive aphasia program, CHAT. But before we hear from Jade, I'm just going to cover off on some important points. You can connect with the Aphasia CRE on social media via Twitter and Facebook, and we do now have our blog where you can read all of our latest findings and, importantly, our calls for research participants. So you can subscribe to that blog to receive updates through email. And as always, please feel free to tweet along with today's seminar using the hashtag AphasiaCRE, or you can use Threads if that's your new thing. Please note that this seminar is being recorded for future viewing. The Aphasia CRE's YouTube channel contains most of our past seminar recordings, and today's seminar will be uploaded within a couple of days. And you can subscribe to that channel to receive notifications about all our new videos. During the presentation today, you may have questions for Dr. Dignam. You can write your questions in the Q&A function down on the Zoom toolbar at the bottom of your screen and not the chat box. You can enter that question anytime throughout the presentation. And the way it works, if you haven't seen it before, is you can see all of the questions that people ask. And if you also want to hear a question asked, you can like or upvote that question. At the end of the presentation, Jade will answer as many questions as we have time for, but please do reserve the Q&A spot for questions rather than comments, and keep your questions brief. All right, it's now my privilege to introduce our speaker, Dr. Jade Dignam. Dr. Dignam is a certified practicing speech pathologist and a postdoctoral research fellow at the Queensland Aphasia Research Centre in the University of Queensland. Jade obtained her PhD from the University of Queensland in 2016, and her doctoral thesis investigated the efficacy of one of the world's first published intensive comprehensive aphasia programs. She currently leads the QARC flagship project evaluating the implementation and effectiveness of the Comprehensive High-Dose Aphasia Treatment Program, CHAT. CHAT is Australia's first modified intensive comprehensive aphasia program to be embedded within a clinical healthcare service. Jade has also worked clinically in acute and rehabilitation health services across Australia, and she's passionate about supporting the translation of research evidence into clinical practice in order to improve clinical outcomes for people with aphasia. So welcome, Jade. Thank you for presenting today. I'll let you share your screen.
Excellent. Thank you, John. Okay, thanks, John. That's quite an introduction. We do love an acronym and we try and fit as many as we possibly can in. So today I'm thrilled to be presenting on the CHAT program, which is the Comprehensive High-Dose Aphasia Treatment. And to start with today, I'd like to acknowledge that this is a research collaboration between the University of Queensland. Sorry, I'm just having trouble with my slides. Oh, there we go. This is a research collaboration between the University of Queensland's Queensland Aphasia Research Centre, or QARC, and the Speech Pathology Department at the Surgical Treatment and Rehabilitation Service. So STARS is a tertiary teaching rehab facility located here in Brisbane. And I just wanted to start today by acknowledging the significant contributions of my co-authors in this work, because there's a significant number of people who've contributed to this body of work. So intensive comprehensive aphasia programs are an emerging service delivery model in aphasia rehabilitation. Miranda Rose's survey in 2013 outlined the key elements of an ICAP. An ICAP is defined as containing intensive therapy provided at a minimum of 3 hours per day, 5 days per week for 2 weeks. And therapy is delivered in a range of formats. So it includes a combination of individual and group-based therapy. And therapy aims to address multiple levels of the World Health Organization's ICF model. Important component is that it provides the inclusion of education to participants, and family members are a key component of this. And the therapy is provided in a cohort design, where a group of participants start and finish the program together. So we have an emerging body of evidence to support the clinical efficacy of ICAPS, with improvements noted in participants' language impairment, in their overall aphasia severity, their communication function, as well as non-linguistic measures. So we've seen improvements in participants' psychosocial wellbeing and quality of life. To date, few studies have evaluated the effectiveness of an ICAP when it's been delivered as part of a clinical service. An important study to note is conducted by Alex Leff and colleagues, and they evaluated the effectiveness of the Queen's Square ICAP when it was delivered within the NHS. In this study, they provided 100 hours of aphasia therapy to 46 participants with aphasia, and it was delivered over 3 weeks. So it's quite a high amount of therapy delivered over 3 weeks. And this study found significant improvements across domains of the comprehensive aphasia test. In particular, they found improvements in spoken picture description, but they also found improvements in carer-reported communication effectiveness using the SETI. So we have some evidence that this model of care is effective when it's delivered as part of a clinical service. The University of Queensland has developed a modified ICAP called CHAT. So CHAT includes participants with aphasia and their family members as partners in the program. It includes a provision of evidence-based goal-directed treatment and is founded upon principles of neuroplasticity. As part of this program, a holistic biopsychosocial approach is employed. At the heart of the CHAT program is the person with aphasia, their family, and their communication goals. So the treatment is goal-directed, and the participants' goals enable or determine the treatment that's provided. The CHAT program includes 14 hours of evidence-based impairment therapy, and this therapy aims to remediate participants' underlying linguistic deficits. So this may include deficits at the word level, sentence level, or discourse level. It also includes 14 hours of functional or activity and participation-based therapy. So this treatment component looks at using participants' communication skills in functional communication environments. It includes 14 hours of computer or technology-enhanced therapy and 8 hours of psychosocial group therapy. And I'm going to go into each of these treatment components in further detail. So this program has been iteratively developed over the past 10 years. The initial program was known as Aphasia Lift, and we conducted a number of clinical efficacy trials to evaluate this program. And these studies focused on factors such as the dose of intervention, the intensity and duration of the program. They also looked at different inclusion of different program elements. So for example, the inclusion of technology-enhanced therapy. Following on this, we conducted a process evaluation where we collected feedback from speech pathologists, people with aphasia, and stakeholders, including service managers, and incorporated recommendations and changes into the program. As I said, this program was developed over a 10-year period, and obviously the evidence base for aphasia rehabilitation has developed during that time. So it's also included incorporation of the latest research evidence. So the program has been iteratively developed over 10 years. To give some perspective of where this research study that I'd like to present today sits in the research timeline. So the initial trials of Aphasia Lift were conducted in early 2011. Today I'd like to present on the results of the clinical delivery of the CHAT program at STARS. So to date, Over 39 trials of LIFT or CHAT have been delivered, and the study I will be presenting today is a single-site hybrid clinical implementation and effectiveness trial. And this is a prospective, non-randomised trial that will be used to inform our phase 3 multi-site hybrid implementation and effectiveness study. So that is our NHMRC CHAT partnership study that is currently underway, collecting usual care data. And this study will compare usual care with the outcomes of CHAT. So today I'll be presenting on the data collected from STARS. The aims of this study were to evaluate the effectiveness of CHAT when it was delivered as part of the clinical speech pathology service at STARS based in Brisbane, Australia. So this pilot study will be used to inform our phase 3 study, which is currently underway. This research is being conducted in collaboration with the speech pathology department at STARS. And we are incredibly fortunate to have 2 full-time speech pathologists employed by Metro North Health and based at STARS, who are responsible for the delivery of the CHAT program. These speech pathologists are supported by the multidisciplinary team with input from medical, social work, occupational therapy, speech pathology clinical assistants or AHAs, as well as students on clinical placement. So the study I'm presenting today will look at the clinical outcomes of delivering CHAT as part of the service here at STARS. And this study is hybrid clinical implementation and effectiveness study. And I'd like to acknowledge that my colleague, Dr. Kirstine Shrubsole, will be conducting the evaluation of the implementation of CHAT. So this program is being delivered as part of your usual care speech pathology caseload. And as part of that, then, our intake and recruitment criteria have had to be very broad. So we are recruiting patients who have a confirmed stroke on medical imaging. They have a diagnosis of aphasia, and that diagnosis is made by a speech pathologist using a formal assessment such as the comprehensive aphasia test. We are recruiting patients who are more than 1 month post-onset, and we have excluded patients who have an absence of functional English skills in those of non-English speaking background, or patients who have the presence of a significant comorbidity that would prevent participation in aphasia rehabilitation. And that decision is made in conjunction with the multidisciplinary team. And essentially the criteria is looking, is this person a suitable candidate for rehab and would they be accepted into rehab? And if that's yes, then they're able to come into CHAT 2. So we have a comprehensive research battery that we complete with each participant, and this includes a measure of participants' language impairment, which is the comprehensive aphasia test, a measure of functional communication using the SETI, measure of communication confidence and quality of life, and then finally we're administering the scenario test. And the scenario test is a reasonably new assessment that is a performance-based measure of functional communication. In addition to the clinical research battery, that we administer, the speech pathologists are able to administer further clinical assessments. And these may be administered to help inform their clinical practice or to measure the effects of a particular treatment that they're conducting with the patient. So some examples of these assessments would be things like getting a better understanding of a person's language profile using the PALPA, looking at the Northwest assessment of verbs and sentences, so looking at someone's sentence processing, or a measure such as the Boston naming test. So there's some flexibility in those assessments. So following on from our assessment, we conduct a multi-step collaborative goal-setting process with the person with aphasia. And as I said, this research has been going on for 10 years now, and one confirmed thing that's come out of it is that goal setting is challenging. So this is a process that, again, we have developed over time. The initial step involves providing education to the person with aphasia about what goal setting is. So what is going to be expected of them? As part of this, we look at identifying what is a short-term goal, what's a long-term goal, and what might be feasible to achieve in an 8-week period. Again, before having the patient come in for their goal setting sessions, We look at collecting as much information as possible from the patient. So we collect information about their family, their history, their interests, their social connections, trying to get as much information that may assist goal setting. We then have a collaborative goal setting session with the person with aphasia and their family members, where we try to identify 2 to 5 short-term communication goals. These goals are led by the person with aphasia, and we then have them prioritise their goal in terms of what is most important to them. We provide patients a copy of their written goals, and then because the goal setting is so central to the therapy provided, they are reviewed regularly during the therapy. So some examples of goals that we have targeted in this program include things like to check in at a medical appointment, to find the words in conversation when talking with family and friends, to meet another person with aphasia, to make small talk with parents at daycare. So these are all fairly typical goals. We find that they do spread across communication domains. So some involve comprehension, some involve reading and writing. We conducted an analysis of goals from the first 12 months of participants who were from the CHAT program. And when we looked at this, we found the most frequently occurring goals were around word retrieval and participation in conversations. And that's not surprising given that anomia is a key deficit for most people with aphasia. What was interesting in this was the third most frequently occurring goal was for people to send text messages. So that really is an emerging area. One thing to be cautious of with this is that this data was collected during COVID. So it's possible that people's behaviours were influenced by that situation as well. So we have assessment and we have goal setting. Following on from that, we have what's called our clinical planning day. And this is a really unique element of CHAT. And I have to say it's probably my favourite component. But this is where the researchers and the clinical team come together. We also include an implementation scientist and a technology expert. And we develop evidence-based action plans to address participants' individual communication goals. So this clinical planning process is done collaboratively. It's essentially like a case conference for each of the participants. So it starts with an overview of their assessment outcomes. We look at participants' goals, and in some cases, it's necessary to have a look at their goals and potentially calibrate them with regards to their assessment results. So, for example, we might have a patient whose goal is to read a novel over the 8 weeks, but then we look at their assessment results and they might still be breaking down at the single word level for reading comprehension. So really just checking that their goals are in line with their assessment results. We look and see if any further assessment is required. So for example, if a participant had a goal around reading, do we need to further identify where that breakdown is occurring? And then we develop these evidence-based action plans. So we look at what are the possible treatment options that could be used to address this goal, acknowledging that many clinicians will use different approaches, and then we discuss and come up with a plan for that person. As part of this, we identify personally salient treatment stimuli. So what are we going to target as part of their treatment? And look at things like what words, what word class. We might look at things like how big a set size and how many words we will treat. And then we look at who we need to engage with. So who from the multidisciplinary team do we need to work with? And even at the early planning phase, we start looking at discharge planning and self-management. So it's a really integral component to the program, and it supports, part of it supports the implementation of the program, but also the treatment fidelity. Okay, so following on from assessment and goal setting and clinical planning, we then start the program. So the CHAT program contains 50 hours of evidence-based therapy, and this is typically delivered 2 to 3 hours per day, 3 days per week over 8 weeks. So this is an example of an individual's timetable for CHAT, and it looks mostly reasonable. It can become quite challenging when you think sometimes we have up to 8 patients receiving CHAT at the one time. So the timetable can get quite busy. Now, as I said, this is a modified ICAP, so it doesn't actually meet the criteria for intensive delivery of therapy. So according to the definition, intensive therapy was 3 hours a day, 5 days a week for 2 weeks. Whereas in this case, we're looking at about 6 to 7 hours a week over 8 weeks. Okay, so I'm going to give a little bit more information now about what each of the treatment components contains. So as I said, this slide's quite busy, but it's just to give an indication. So impairment therapy aims to address participants' underlying linguistic deficit, and that might be at the single word level, the sentence level, or at a discourse level. Now, this slide here is just an example of the decision-making tool we use to guide our decisions around what type of treatments we can include. Now, this isn't an exhaustive list, but this is some of the more common evidence-based treatments that are available in aphasia rehab. And so, for example, you can see if a person with aphasia had a goal that pertained to oral language, so and potentially looking at auditory comprehension of sentences. So they want to understand sentences better, or they're breaking down in conversation because they're not understanding and the deficits occurring at the sentence level. Some of the evidence-based treatments that we could then use or consider would be mapping therapy, treatment of underlying forms, or VNEST. And then as part of our clinical decision-making day or clinical planning day, we will have a chat about the patient and their particular circumstances and language and cognitive profile, and look at which of these treatments do we think is best. So, for example, if someone had perhaps quite significantly impaired auditory comprehension with potentially a cognitive overlay, we might not choose treatment of underlying forms for that patient, but instead might argue that a mapping approach would be more suitable. So there's not hard and fast rules with this. And this decision-making tree is regularly updated as new treatments are coming out and new evidence is being made available, but it is helpful to guide our decision-making. So the other thing is there's not one particular impairment therapy that is used for every patient. So the treatment is comprehensive, but it's personalised. So depending on what the goals are, the impairment therapy will differ for each patient. And again, this is just an example of the decision-making tree to guide our selection of evidence-based treatments for written language. So looking at reading comprehension and spelling. So following on from impairment therapy, we have functional therapy. Again, I'll say this a bit, but it's goal-directed. Initially, at the start of therapy, we really try and situate the context of the goal. So, for example, if someone's goal is to talk on the telephone, we look at who they're talking to, what are their topics of conversation, how frequently they might be doing that, where is the challenges, what are the breakdown, and how can we better support that? So we collect that baseline information, looking at things like their social and their environmental inventory. So where are they going and who are they talking to? We then also conduct a task analysis. So for functional therapy, what we want to know is how are they performing at the moment? What are the steps they need to do to successfully complete their goal? And how can we better support them to do it? So we look at things like where is their breakdown occurring? Where is the challenge occurring? But also looking at things like what are their strengths? How can we maximise their communication abilities? So we look at putting in place supports or compensatory strategies to facilitate that. We look at introducing challenges and variable practice so that it's not just practicing the single task in the one environment or context, and looking at how we can incorporate metacognitive strategy training or problem solving into those therapy components. Consistent with both impairment therapy, repetitive practice of this is key. So there's a high within session intensity in this program, and we acknowledge that practicing an activity or a task just once is unlikely to lead to success. So we require repetitive practice of these tasks. So some examples of activities or approaches that are used in functional therapy. It may include things like training of AAC, communication partner training, provision of education, role play or script training, metacognitive strategy training, training of computer skills. So there's quite a few different approaches. And again, this really comes back to what the goals of the person with aphasia are, their profile and their strengths and weaknesses, and how we can best support that. Following that, we have computer therapy. So computer therapy, again, directly targets the goals of the person with aphasia and aims to reinforce the skills and tasks trained both in impairment and functional therapy. Where possible, tasks and stimuli are personalised for the individual. And again, we focus on that intensive repetitive treatment. So these are a couple of the common evidence-based computer software programs that we use in chat. So for example, step-by-step, listen in, I read more, constant therapy. Finally, we have group therapy. So this includes 8 one-hour sessions, so once a week, with a predominant focus on education. So they include some lecture-style presentations from guest speakers around things like what is a stroke, what is aphasia, neuroplasticity and recovery, communication partner training and education around communication and identifying strategies to support communication, conversation practice, but it also has a focus on living successfully with aphasia and linking participants in with community aphasia groups. And finally, there's a component of education and discussion around self-management, particularly with a focus on what happens after chat. So today, I'd like to present some of the clinical outcome data from this study. So chat was implemented at STARS in 2021, and today I'm going to present the data from the first 8 cohorts. So this is collected over 2021-22. During this period, we received 151 inquiries into the chat program, and we consented 45 research participants. The primary reasons for exclusion included referrals from patients who were outside of the area or interstate, patients who had aphasia resulting from either a TBI or a progressive neurological condition. And we had some patients who had declined, mainly due to logistical reasons. So for example, transport. Okay, so participants had a mean age of 65 years with a range of 35 to 86 years. So importantly, there's no age cutoff on who's eligible, and we found people as old as 86 have been able to complete the program. We had 30 males and 15 females complete chat. Now, participants had a mean time post-onset of 27.8 months, but as you can see, this is largely affected by an outlier at 283 months. So the median time post-onset is about 9 months. And what we've seen in the typical pathway of patient flow has that patients have come through their inpatient rehab, outpatient rehab. They might have received a period of rehab in the home, and then they're often referred through to chat. So to date, 43 out of the 45 participants from the first 8 cohorts completed the program, and we've had 2 participants withdraw due to the acute onset of new medical issues. We had 1 participant who did not complete the post-assessment, and we had 5 participants who were lost to the 3-month follow-up. The mean dose of therapy provided was really high. So we found on average participants received 46.8 hours of therapy, which is huge, and over 2,000 hours of therapy was delivered by the clinicians. So to evaluate changes in participants' communication, we collected outcome measures pre and post therapy, and then again at 3-month follow-up. We evaluated group level changes using linear mixed models, and we also looked at the magnitude of the changes using Cohen's d effect sizes. We've then also looked at changes at the individual level using the minimal detectable change 90. Okay. So the comprehensive aphasia test modality mean. So this score takes an average of participants' performance across communication domains on the CAT. So for example, auditory comprehension, written comprehension, repetition, naming, across all of the domains. And so we've seen a significant improvement across on the CAT modality mean at post-therapy. And this is associated with a small effect size. And again, this is maintained at the 3-month follow-up. We've seen significant improvements in participants' functional communication as measured by the SETI, and this is associated with a large effect size. And again, this is maintained at the 3-month follow-up. We've seen improvements in communication confidence with a medium effect size post-therapy and a small effect size at follow-up. And then we've seen significant improvement in participants' quality of life, both post-therapy and at 3-month follow-up. And this result is largely driven by an improvement in the communication domain of the SAQOL. So what we see when we look at that particular domain is a medium effect size, both at post-therapy and 3-month follow-up. When we look at the individual participant data, so these graphs here, if the line is above 0, that indicates that the participant made an improvement, and if it's below 0, that they did not. So we've seen a number of individuals demonstrated improvements on the CAT modality mean, both post-therapy and at 3-month follow-up. That dark purple line there indicates the MDC90, so patients who have made a significant improvement greater than what is considered the minimal detectable change. So that's on the SETI is greater than 11.53. And we found 23 out of 25 participants made a significant improvement post-therapy, and 14 out of 18 made an improvement at follow-up. And then on the SAQOL, we found that 19 out of 42 demonstrated a significant improvement post-therapy, with 13 out of 35 demonstrating a significant improvement at follow-up. And so there's not currently an established MDC90 for the communication confidence rating scale. But again, we've seen some improvements across the board for participants there. So now I'd like to quickly present an individual case study to give you an indication of what this looks like in practice. So this is Jim. Jim is a 54-year-old male who experienced a large left MCA territory infarct. He's 6 months time post-onset when he starts the CHAT program, and he presents with a severe receptive and expressive aphasia. He lives at home with his wife and his 2 young children, teenage children, and he had previously worked as a lawyer. Jim has a particular interest in music and in playing the guitar. So his goals for CHAT included to improve his conversation with family and friends by better understanding what they are saying and by finding the right words. He also wanted to increase his independence, and in order to do that, he wanted to be able to communicate for help in an emergency and order coffee at a local coffee shop. So this here is just a general overview of his therapy program, but I'll go into detail with this now. So he presented with severe receptive and expressive aphasia, and Jim was breaking down at a single word level, both for auditory comprehension and spoken production. The speech pathologist conducted further baseline assessment. So they looked at his language processing using the PALPA, and they also conducted a baseline naming assessment. From here, they developed a core vocabulary of personally meaningful words for Jim, and this included 2 sets of 10 stimuli, and they were made up of both nouns and verbs. His impairment-based therapy included psycholinguistic therapy, aiming to remediate comprehension of single words. So it included tasks like spoken and written word to picture matching, spoken and written word picture verification. It also included training of single word retrieval, and this included approaches such as semantic feature analysis, phonological component analysis, and repetition in the presence of a picture. One of the key principles with Jim's therapy, given the severity of his aphasia and his auditory comprehension impairments, most of his interventions included multimodal presentation of both the auditory word and written word. Okay, in terms of his functional therapy to address his goals, so he wanted to participate in conversation, he wanted to communicate for help, and he wanted to order a coffee. a key element of his treatment was communication partner training. And this looked at providing education and training to his family members, but also his NDIS support workers. And that made up a large element of his functional therapy. The speech pathologist introduced the use of AAC, both as a compensatory approach, but also part of his ongoing practice and training. And this AAC included things like personalised topics of interest to generate conversation, and they conducted training with his communication partners, so his family member and his support worker, with how to use this and how to support him to use it. He also, as his goals were to communicate help and to order a coffee, the speech pathologist looked at how he was going with this, a baseline, and they developed personalised script and role play to target this in a functional and meaningful context. As part of this, they identified what strategies would support him to achieve this goal. And so, for example, that he was provided with a personalised aphasia card, and they had his medical ID set up on his iPhone. They also trained explicit training in the use of metacognitive strategies. So, for example, in conversation, he was having trouble with auditory comprehension, training the use of strategies to confirm when he had understood or to clarify if he hadn't understood, and also training the use of total communication strategies. So his verbal output and expression was significantly impaired, so looking at maximising his communication using total communication. As part of this, the speech pathologist worked closely with the OT, so for example, making sure he was set up with a pendant alarm. In his computer therapy, again, this reinforced the activities and tasks that were trained in both impairment and functional therapy. So he was set up with step-by-step software, and this contained his core vocabulary that had been identified by the treating speech pathologist in conjunction with Jim, and included auditory and reading comprehension of single words, as well as training of word retrieval. He also practiced using aphasia scripts. So he had his personally developed emergency situation and coffee order scripts. And he also trained using the 4-in-1 Tactus therapy program. Again, given Jim's significant aphasia, there was a focus on self-management and what would happen at the end of chat. So the treatment approach included support for long-term management. So setting up technology at home to support him for beyond chat. So for example, he was set up with a step-by-step home license and had training in how to use that at home before the end of the program, and also linking him in with aphasia support groups. It included the provision of education to family and support workers. And also, he had interests around music and aphasia. So for example, the music therapist was invited to participate in our group therapy schedule, and Jim was referred to the aphasia choir. He was also working quite closely with the OT on returning to playing the guitar. And as part of this, they made a referral to rehab engineering for modifications of his guitar. So really aiming to support his participation in as many ways as possible. So Jim just demonstrated a significant improvement on the CAT modality mean at post-therapy in terms of his individual outcomes. And you can see he made improvements in auditory comprehension and naming, although this didn't meet the criteria for a significant improvement, but he made a significant improvement in written comprehension, which is interesting given the presence of the written word form as part of a key element of his therapy. Again, given that total communication and communication supports was a key element of Jim's therapy, it's nice to see that we saw a significant improvement on the SETI, as well as an improvement in his quality of life on the SAQOL and improved confidence on the CCRSA. So in addition to clinical outcomes, we're also collecting outcomes regarding consumer satisfaction with the chat program. So at the end of the program, we complete a 34-item survey to participants with aphasia. It includes open-ended questions and a 5-point Likert scale. On a scale of 1 to 5, in terms of being satisfied with the program, participants report a mean of 4.7. So we're seeing high satisfaction with the chat program, and participants have reported perceived improvements in their communication and their confidence. When we look at the qualitative data, Participants have reported a real benefit of the group nature and the benefits of the cohort for this model. So participants have said it's helped them understand that they're not alone in their difficulties, and that they're able to see other people's challenges, but also successes over the 8-week program. In terms of constructive feedback, with regards to group therapy, there was consideration of the group dynamic. So, for example, the different types of aphasia severity that might make up the group, as well as providing more opportunities for less structured communication. And then with regards to individual therapy, what really came out as being important to the participants was the personalised nature of the program and the fact that it was tailored around their personal goals. When we look at, I guess we ranked the satisfaction rating scale from questions, and we looked at what was the lowest question. So the question was 8 weeks a good amount of time for chat? And we found, so we looked at this for the first 12 months of participants, and we found that 20 out of 23 participants wanted more therapy. Interestingly as well, participants reported that they participated in this program, and coming in regularly and having a schedule that was quite intensive gave them a real purpose, but upon completion of the program, they felt this sense of loss. So my colleague, Dr. Jessica Campbell, developed a home maintenance program called Chat Maintain. This is a 6-month low-dose technology-enabled program, and this aims to support the maintenance of treatment gains following intensive therapy. This research is supported by a Stroke Foundation grant, and data collection is currently underway to evaluate this. I'm just going to skip that. There we go. So we have delivered 12 cohorts of chat successfully at STARS now, and it's been delivered by the STARS speech pathologist. Patient recruitment has been steady throughout the course of the last 2.5 years, which is amazing. We have seen improvements on participants' measures of language impairment, their communication function, quality of life, and confidence. And for many of these measures, these gains have been maintained at 3 months. As you would expect for people with aphasia, we have seen much individual variability in treatment response, and some of this is related to the heterogeneous nature of aphasia, but also looking at individual participant goals, that people set goals across different domains. What is nice is that we've, again, in addition to these positive clinical outcomes, we've received really strong, high consumer satisfaction with the program. And I'd just like to share some of that now.
The improvement was massive. It was so different from what it had been 8 weeks before.
It just got easier and easier and easier, and it's mainly because of what happened of that whole program.
His confidence, his self-advocacy, the confidence that he had in the meetings, in the group meetings, were like, oh yeah, like pick me, I can talk about that. What it did for us was give us back enormous richness about what 50 years of life had been together.
We came away from that saying, this is just outstanding. This is just wonderful.
The improvement.
Okay. So data collection for this study is still underway at STARS and will continue through to the end of 2023. And then chat will be offered as part of their clinical service at STARS going forward from 2024. As I said, we've got a number of research projects going on from this, including a Chat Maintain program, which is the home maintenance program. And this is feeding into our phase 3 hybrid clinical implementation and effectiveness study. But I'd just like to acknowledge and thank the participants with aphasia and their family members for contributing to this research, and also acknowledge the contribution of the STARS Speech Pathology Department. Thanks.
Thank you so much, Jay. That was, I must say, very easy to listen to, and it's an incredible program. 2,000 hours of therapy, over 40 people, and it's just amazing to see the, you know, what used to be opposed, the impairment versus functional versus all of that brought together. It made me think, in some ways, you know, we've got ICAPS as this thing, this entity, but really, in an ideal world, that should be just aphasia therapy. Like that's how it should be, all of that brought together, that intensity. Yeah. Thank you for presenting that. We do have some questions, but I'd like to start with my own. And one is just, I'm interested in whether you think there's one of the elements of an ICAP that is particularly potent or particularly meaningful to people, or is it really the combination of all of them?
I do think it is a combination of all, but I don't think you could achieve it without the high dose. So I think in that 50 hours, it really gives you the opportunity to go in depth with things like impairment therapy and really acknowledge your, activity and participation targets. And I think if you didn't have sufficient dose, you wouldn't be able to do that. So I think it's all important. I don't think you could just have one element, but I think you wouldn't be able to achieve it without the high dose of therapy.
Yep. Thank you. All right, we'll go to the Q&A box. Celine Wong is asking, was there any difference in outcomes when comparing clients with mild and severe aphasia?
So we haven't conducted an analysis to look at what sort of factors predict outcome yet, and we're still collecting data. So we're hoping for a target of about 75 patients by the end of the year. And then hopefully that data set will be big enough to start looking at who responded versus who didn't. So we're looking at things like cognition as well, so cognitive factors, severity of aphasia, age, and we'll use that data to start looking at who is actually a good candidate for an ICAP. There's some suggestion that people with mild aphasia may not need as high a dose, but I sort of counteract that by saying often their goals are more complex in terms of getting them back to work. So I don't think we can make those sort of calls just yet.
And perhaps less apparent on a typical aphasia assessment.
Yeah, harder to measure and harder to treat.
And would you be looking at time post onset? Because it would be interesting if that did.
Yeah,
and more interesting if it didn't make a difference.
Yeah, we will. So I mean, in the past we've looked and found that time post onset didn't affect outcomes, and some of our early data with aphasia lift showed that people who were chronic and further down the track still made significant gains. But from a service perspective, it's something else we need to consider.
Kira Shiggins asking, thank you so much, Jade. Wonderful presentation. Can you tell us a little more about how you came up with the dose and intensity of therapy for chat?
Sorry, I'm going to reference Dave Copeland and Linda Worrell for this because Aphasia Lift was initially a program that they collaboratively developed. And in those early phase efficacy studies, they piloted a number of different doses and intensities. So I think the first one was maybe 30 hours, and the feedback from participants was that they wanted more. So then they went up to 100 hours, and the feedback from participants was they needed much less. And so we settled on about 50. That sort of met patient needs. So they weren't too fatigued or exhausted to participate, but it was a sufficient dose. And this research was conducted before some of the data from the individual participant data studies that's looking at optimal dose was available. So it was kind of pilot studies that used to determine that dose. Yeah.
Thank you. Kate Dallenbach says, could you comment on any apparent commonality among clients who did particularly well with, oh, my sensor light's just gone out, did particularly well with chat and those who did not see as much progress?
Yeah, again, we haven't looked closely at who's able to respond. We know going into the program that there are some indicators that would suggest someone is potentially less likely to make change. So, for example, if they present with a really severe aphasia. Having said that, we will still continue to give them impairment-based therapy and try and maximise their outcomes with that. But we might, so for example, like the case study, really make sure that we're focusing on building on their strengths and incorporating alternative strategies to maximise their communication as well, should we not see those improvements. Having said that, we do have some participants who've had very severe aphasia and who have surprised us by doing incredibly well on impairment-based measures.
Yep. Richard Lindley said, thanks, Jade, lovely presentation. You're presenting a fantastic program, but how is this funded? In the west of Sydney, we can barely get one session of speech pathology for a person with aphasia.
Yeah, so this it really comes back to that 10-year iteration of the program and developing partnerships over that time. So the research side of it is funded through the Queensland Aphasia Research Centre, which is based on philanthropy. But what happened over that 10 years is we worked very closely with one of our health services that we partner with regularly, and they made a case that they needed increased services for people with aphasia. And it started with initial small grant from a Stroke Foundation funding, but that partnership's developed over 10 years. And they've eventually been able to successfully build the case, certainly over the last 2.5 years, that they needed dedicated staff for the delivery of aphasia services, which is quite amazing.
And so is the hope, I guess, long-term that the case is very strong, that a lot of services can do that and make that case and call for that funding?
Yeah, ideally that would be a great outcome.
Yeah. Chloe Douglas says, hi, great program. Any plans to extend inclusion criteria to support people with aphasia post localized TBI?
At this stage, we're just focusing on stroke. And you will have seen there's a number of other projects that are happening around implementation of this in post-stroke aphasia. So we haven't looked outside that field yet. Having said that, our inclusion criteria are reasonably pragmatic. So we are including people with subarachnoid hemorrhage. And so we are seeing some patients who present with slightly more COG-COM presentations than you would expect in a typical research trial.
Yeah.
So that's...
I mean, you would think that because this wraps up so many important principles like dose and intensity, holistic, functional, that there's just so many neurological conditions where this would be an appropriate kind of...
And I guess the founding principles of this program are, best practice. So what is best practice in terms of comprehensive care, intensity of care, patient-centered care?
Celine Wong asked, in terms of resourcing, if there were 2 FTE speech pathologists, how many clients were able to join the program at one time?
So the maximum we've delivered it to at any one time is 8. And that's quite busy for the clinicians.
Yeah, I can imagine.
Yeah.
Emma Woods, just curious if you have any further details on how the patient who was 283 months at the time of participating benefited from the program, either in terms of outcome measures or just their experience engaging in such an intensive program so far since time of onset.
I'd have to go back and clarify this patient, but my sense was that they were they were 20 years post, essentially. And so the field had moved on quite considerably. And there were a number of new things that we could offer them, including technology support, that really blew their mind. So I can't comment on how they went from an impairment perspective, but I do remember quite clearly from a functional participation perspective, there was quite a lot of new treatment approaches and supports that they could access that they didn't know about.
I suppose it's almost impossible not to benefit in some way from a program, even if someone doesn't improve at impairment level.
Yeah, and that's that's right.
Yeah. There's always something functional or something, even just meeting other people. Yep. A couple of more questions from me. One is just interested in the decision to use the CAT as the kind of aphasia severity measure. I mean, it's very widely used clinically, but in terms of research, the WAB is sort of officially the preferred measure. So I'm interested in why it was felt that was.
It was a really difficult decision to make, that one. And at the end of the day, it came back to the fact that we were implementing it in a clinical service, and it was the measure that they used. So we felt we were already changing enough of their practice without then also changing their assessment tool. So we were really guided by the clinicians on that. We did also know that Alex Leff and his colleagues were using the CAT as an evaluation for the Queen Square ICAP in the UK. So it did mean as well that potentially down the track we could look at comparing that data too.
Yep. Wonderful. Well, if there's no other questions, I'll just briefly talk about our next session. But thanks again, Jade, for presenting that. It's an incredible program, and I think everyone would love to see one in their nearest health service or their university. So thanks so much.
Thanks, John.
Okay, so we have our next CRE seminar is going to be presented by Dr. Alexi Shavonin, who is presenting to us on music-based interventions in aphasia rehabilitation. And you'll note that this seminar is just a few weeks away instead of a full month. It'll be Wednesday, the 16th of August. So follow us on Twitter and our blog for details of how to register for that seminar, and hope to see you then.